طيب السلام عليكم. طيب, as usual, the source for this presentation will be from UpToDate and NCCN. During this presentation, it will be an overview for gastric cancer and pancreatic cancer. We'll start with gastric cancer. The incidence of gastric cancer is high in Japan, Korea, Venezuela, and Chile. It declines rapidly worldwide, maybe due to the following: recognition of certain risk factors, which is H. pylori, dietary, and environmental. Use of refrigerators, which reduce salt-based preserved food, which prevent bacterial and fungal contamination. Fresh food source of antioxidants. However, it is rising in young patients in recent years for an unclear reason. Here are the symptoms of gastric cancer: abdominal pain, like ulcer type pain, like hunger pain, nausea, early satiety, dysphagia, melena, and weight loss. Physical exam. In the physical exam is very non-specific, but you may find some epigastric fullness or tenderness. In later stages, you may find hepatomegaly or ascites. This is one of the specific signs for gastric, and maybe for pancreatic cancer too, which is virtual nodes, which is the left supraclavicular lymph node enlarged. Enlargement of left anterior axillary lymph node called Irish node, or Sister Mary Joseph nodule, or a sign which is a periumbilical nodule. Krukenberg tumor, which is a drop metastasis to the into the ovaries, or Blummer shell sign, which is a drop metastasis to the cul-de-sac. There are some paraneoplastic features characteristic for gastric cancer, like Tourzious syndrome, which is migratory thrombophlebitis, microangiopathic hemolytic anemia, almost like TTP, membranous nephropathy, polyarthritis nodosa. There are some dermatologic presentations, such as eruption of diffuse seborrheic keratosis, sign of the laser telomerase, and acanthosis nigricans, which is a soft, dark, pigmented patches on skin folds. Risk factor: H. pylori, and there is some family history of certain inherited diseases, such as hereditary diffuse gastric cancer due to gene mutation CDH1, and gastric adenocarcinoma and proximal polyposis of the stomach, a familial intestinal gastric cancer. There are some pathologic variants that, if found, the patient should be tested for H. pylori due to the risk factor of gastric cancer. So those patients should be tested for H. pylori and eradicate the bacteria to prevent development of gastric cancer. Salt preserved food, as we said, food low on vegetable and fruit. In nitroso compounds, obesity is a risk factor, smoking, alcohol, coal mining, and EBV is a risk factor for gastric cancer. There are some precancerous conditions. For the intestinal type cancer, chronic H. pylori infection, pernicious anemia, high salt diet. These lead to chronic atrophic gastritis and intestinal metaplasia, or gastric atrophy or resection, which leads to hypochlorhydria, or atrophic gastritis, autoimmune. Both lead to hypochlorhydria, which ultimately result in hypergastrinemia, which will result in increasing gastric pH that lead to bacterial alkalization, which convert dietary nitrates into N-nitroso compound, which is a risk factor for gastric cancer. Intestinal metaplasia and dysplasia caused by H. pylori infection or bile reflux. In case of diffuse type cancer, this is an inherited type, there is no precancerous lesion. So on this presentation, I would like, as usual, to make a case so we can follow that. And please, if you want to share your answer, it would be great. So this is a 75-year-old female patient with family history of breast cancer, presented with abdominal fullness. She was found to have iron deficiency anemia. Endoscopy revealed gastric ulcer. biopsy unfortunately showed signet ring adenocarcinoma. What test or test you may order next? Choose all correct answers. Would you do an EUS, endoscopic ultrasound? Would you do a PET CT scan? Would you do a laparoscopy? Would you check the biopsy for HER2 status? Would you check the biopsy for MSI or MMR and PD-L1 status? Which one is the best to choose? You can choose the most important to you. So let's just go over the diagnosis and the workup. Of course, EGD with a biopsy. EGD, you may find a friable ulcerated mass, gastric ulcer, or the EGD could show normal stomach in case of linitis plastica. And in this case, barium X-ray is more helpful. Of course, we cannot do biopsy with that, but the EGD may not show any abnormality in that case. But in any case, you do need a biopsy to confirm the diagnosis. Remember, with the biopsy, a good deep biopsy is important. Of course, not to perforate the stomach, but you need to get deeper tissue so you can get can reach staging, especially for early stage. So you need endoscopic resection, which is essential for accurate staging. Of course, you need blood counts, renal function, liver function, CT scan, EUS, if no metastasis, or you may need a laparoscopy. We'll look into those, we'll see those in the coming slides. PET scan, biopsy, you need to check for HER2, PD-L1 testing. If METs are documented or suspected, you need to check for the HER2 status and PD-L1 that's needed for the treatment, especially if you suspect metastasis. Check MSI by PCR or NGS or MMR by ISC, which is easier than the MSI, which you require PCR or next generation sequencing. NGS on the tissue for biomarkers should be considered. And finally, assess for Stewart category, because stomach cancer overlap with the GE junction carcinoma. And here are the Stewart classification. For example, type 1 in adenocarcinoma of distal esophagus, the tumor center for type 1 is located within 1 to 5 centimeters above the gastric cardia. Type 2, basically this is the GE junction carcinoma. Type 3, adenocarcinoma of subcardial cardial stomach. So the stomach cancer could be either superficial, could be focal, fungating polypoid, it could be infiltrative like linitis plastica. The role of EUS is crucial for if early stage disease is suspected, or if early stage versus locally advanced disease need to be determined. So then endoscopic ultrasound is very helpful. Laparoscopic with cytology, that is really important in case of clinical stage T1B, which is invade submucosa. So if you do a biopsy and it showed a good biopsy, which showed invasion into the submucosa, then laparoscopy with cytology is important because you don't want to take patient to surgery if they have peritoneal metastases. So laparoscopy will help you. So when to consider laparoscopy, again, if you consider giving concurrent chemoradiation or surgery upfront, then laparoscopy is important. However, if you're planning for palliative resection, then of course there is no need for laparoscopy. Pathology, 95% of biopsy will be adenocarcinoma. Specifically, it is intestinal, the most common. Diffuse is less common. For the biopsy, all patient with gastric cancer, we should take for MMR and MSI for all patients because it has therapeutic benefit. Check for PD-L1, the CPS, the combined positive score, on HER2 status, and that is only for advanced metastatic or metastatic disease. Next generation sequencing for biomarkers for advanced disease. You may, if you don't have enough tissue, you may do a liquid biopsy. You can find the tumor DNA in the blood. Also, it could lymphoma, sarcoma, GIST tumor, or carcinoma are others, but the most common is adenocarcinoma. Here are the staging system. in the stage system, I think these are the two stages that you need to remember by heart, because it make a difference when you treat, which is all the stages make a difference. But I mean, this is, you need to remember, especially for early stage, stage 1B. So when we talk later on in the slides, remember stage 1, whenever we say stage 1B, try to remember it is a tumor invade the submucosa. Stage 2, tumor invades muscularis propria. So remember those when we go through the slides and the management. Treatment. So we go back to our case, the same patient. She was found to have advanced disease with peritoneal metastasis only, no liver or lung metastasis, no visceral metastasis, only peritoneal seeding. So she is now in your office to discuss treatment plan. What would you recommend? Choose all correct answers. Would you recommend subtotal gastrectomy with D2 lymph node dissection? Would you recommend intraperitoneal chemotherapy because she has only peritoneal disease? Would you check HER2 status? Check MSI, MMR, and PD-L1 status before you go into any treatment? Or would you go ahead with chemotherapy because you have already metastatic disease using FLOT combination chemotherapy? I think if anyone wants to share any, you can go into the chat. So you can do that while we're talking about this, the other slides. So now we go over the non-metastatic disease, the management for those. So for non-metastatic surgery, of course, is the key for treating gastric cancer. Someone said to check the HER2. I like the interaction, if someone can interact. So you can make it more interesting. So surgery is the key treatment for gastric cancer. So when you do surgery, we talk about gastrectomy, and subtotal gastrectomy preferred over total gastrectomy. And the subtotal gastrectomy has a comparable survival benefit and lower morbidity, of course. And when you do surgery, you need a 5 centimeter margin, distal and proximal, to be free, 5 centimeter free. Another mode of treatment is concurrent chemoradiation. If we use concurrent chemoradiation, we use it either pre-operative as a new adjuvant or post-operative. On the other hand, if you use chemotherapy, we do not use chemotherapy as the pre-operative only. New adjuvant chemotherapy is not an option. If you use it, it should be followed by post-operative. So remember, for chemoradiation, you could use it pre or post only, fine. For chemotherapy, if you use it pre, then it has to be followed by chemotherapy. So it is like a sandwich: chemo, surgery, chemo, peri-operative. Or you could use it post-operative, not pre-operative only. Immunotherapy could be used pre-operative before surgery, or it could be used peri-operative. For the surgery, when we do lymphadenectomy for the gastric cancer, the D1 is described as a regional lymphatic or regional lymph node dissection, which is a perigastric, pericardial, paragastric, parapyloric. A D2, which is better, which is more extensive lymph node dissection, because it involved retroperitoneal lymph node dissection following the major vessels like celiac trunk, left gastric artery, hepatic artery, splenic artery, and splenic hilum. If you do D2, the goal is to remove at least 15 lymph nodes to call it a D2. Anything less than that is D1, which is suboptimal. So the extent of lymphadenectomy, it has been proven in retrospective studies. D2 is safe and not increase morbidity if it's done in a place which they have expertise to do that. The improvement in long-term survival rates for Japanese patients was attributed to the fact that they do D2 and they're good about it. There are 2 European randomized trials. Both of them showed no significant difference in overall survival between D1 and D2. However, it showed that higher post-operative morbidity and mortality in D2 due to higher rate of splenectomy and or partial pancreatectomy. I think people make a joke about this. They say because they don't have good surgeon. Because Japanese, they do it and they have less mortality because they do good job in avoiding splenectomy and partial pancreatectomy. A subset of an N2 disease with a D2 dissection showed survival benefit advantage. So having said that about the surgery, it is recommended to do extended lymphadenectomy in specialized centers with people who are, have expertise and have done this a lot. So that way you can avoid splenectomy and pancreatectomy when you do the D2 dissection. These are the reconstructive procedures. This is all for most for surgery. This is for the surgeon. So now for us as a medical oncologist, we worry more about, or we want to be more expert and have more knowledge about the adjuvant therapy. So the adjuvant therapy at the chemoradiation, it has shown a 5-year survival rate after curative resection, 30 to 40%, 5-year survival rate if you do adjuvant therapy. There is a North American intergroup trial. They randomize resected patient with resected or early stage gastric cancer, stage 1B up to stage 4, with an negative distal metastasis. They treat those patients with concurrent chemoradiation versus observation after surgery, and it showed significant improvement in median DFS with the median DFS of 19 versus 30 months, and overall survival 26 versus 35. So it was statistically significant. So the adjuvant chemoradiation became a standard of care in the United States. This is a SWAG trial about adjuvant chemoradiation. They randomized. It was a phase 3 trial. They randomized resected adenocarcinoma of the stomach and GE junction stage 1B to 4A. They gave them 5FU leucovorin for 5 days, and then followed by concurrent chemoradiation, followed by chemotherapy for another 2 cycles, so like a sandwich. So they gave chemoradiation, and chemo, which is a 5FU. And this was a study. This is very well-known study, an old one. I just brought it up because it's still holding it. It was done by McDonald and his group. It was published in 2001, but it's still, this is actually, since that time, the adjuvant became a standard of care. So post-op chemoradiation improved DFS and overall survival in R0 resected locally advanced disease. So it is become a standard of care. So another old study by Cunningham and his group was published also in 2006. Still, this is actually brought to us the perioperative option for those patients. They gave perioperative chemotherapy, ECF for stomach, mainly stomach cancer patients, and 1/3 of the patients are distal esophageal adenocarcinoma, not squamous or GE junction. They gave them ECF for 3 cycles. I think you're all aware of this. Surgery and ECF 3 cycles versus surgery alone, and showed a 5-year survival, 36% versus 23%. The chemotherapy improved resectability and improved PFS and overall survival. So again, become a standard of care. So those studies are old, but since that time, the adjuvant and perioperative chemotherapy now is improving. We're using different chemotherapy other than ECF, but that gave us the roadmap for the perioperative chemotherapy and the adjuvant chemotherapy. So for early stage disease, TIS or stage C, T1A, very early stage. For those patients, if they're not surgical candidate, endoscopic resection is fine. and then endoscopic surveillance. But if they're medically fit, then we do endoscopic resection followed by endoscopic surveillance, or actually you can offer them chemotherapy, especially if it's R1 or R2 disease after surgery, then you give them concurrent chemoradiation. This is for the T1A, the early stage. So what about the clinical T1B? And that's usually find out by EUS. You can tell the clinically if it's a T1B, we said invasion into the submucosa. So this group, if they're medically fit, potentially resectable, then surgery without pre-op is fine. Pre-op therapy. They just take them up surgery upfront. For R0 surveillance, for R0, but in the pathology, if you found after surgery the tumor reach to the muscularis, so the pathologic T2, then you have the option of observation or adjuvant chemotherapy, concurrent chemoradiation followed by chemo. If it's even more advanced, if it's a PT3 and the surgery was less than D2, like a D1, less than 15 lymph node being removed, then for the T3, pathologic T3, you give them adjuvant chemotherapy, chemoradiation, and chemotherapy. Similar like the 5FU followed by concurrent radiation and 5FU followed by 5FU leucovorin. But if it was a D2 resection, you don't need radiation, so chemotherapy alone. If it was a D2 resection, of course, if it's R1 or R2, residual disease, then concurrent chemoradiation, or if it is R2, significant gross disease left behind, then even palliative treatment is fine. So now we are going to the disease more than clinical T1B, which is the T2. Anything T2, clinical T2 or more, that means tumor invade muscularis with any end, regardless, with any end. So those patients, the best is to give them perioperative chemotherapy. So the old study was they use the ECF, but now we're using better chemotherapy, which is less toxic and maybe more effective, like FLOT, carbotaxol, or any platinum-based. That's the preferred. So the preferred regimen is perioperative platinum-based chemotherapy. FLOT is commonly used, which is the 5FU, leucovorin, oxaliplatin, and docetaxel or taxotere. Or the other option is preoperative chemoradiation, which you can use the 5FU with radiation, the LODA with radiation, but perioperative chemotherapy is preferred. You can take them to surgery, of course, as an option. That's why we said all patients should be checked for the MSI and MMR. So if they're MSI high or MMR deficient, then you have an option to take them to surgery, or you can consider giving new adjuvant preoperative or perioperative checkpoint inhibitors. You can use Nivo or Pembro. So if you already chose the perioperative, which is the preferred regimen, you gave them a T2 muscularis being invaded by the cancer, any N, and you chose the perioperative, which is the best. And you said the regimen, any of the chemotherapy, FLOT is preferred. Or if you give them preoperative chemoradiation is fine. But if you give them perioperative chemotherapy, you need to remember you need to give chemotherapy after the surgery. So, of course, after that, you reassess with the PET-CT. And if there is a response and no progression, of course, you take them to surgery. And if it is an R0, no residual disease, negative margins, then and they have the preoperative chemoradiation, you just observe. But if you chose the preoperative chemotherapy, then you give chemotherapy again. So for any chemotherapy without radiation, you give chemotherapy after surgery. Of course, if it's R1, concurrent chemoradiation, if not received previously, or you may consider re-excision. R2, of course, you have to give concurrent chemoradiation if not received, or if gross disease palliative therapy is fine. So for this subset, this is not a lot of patients having that, but if a patient has an MSI high or deficient MMR and you give them preoperative or perioperative checkpoint inhibitor, Nivo or Pempro, then those patients, what you could do, you do a repeat endoscopy and you have a biopsy, and the biopsy showed complete pathologic response and scans negative. So that's a complete remission. So the role of surgery for those patients is unclear. This is similar, if you remember, to the rectal cancer patients who have MSI high or MMR deficient. Remember that a small group was done at the Sloan Kettering. They have 14 patients. They all give them immunotherapy and they have complete pathologic remission. So they only follow them with the scans and endoscopies. So this is kind of similar to that. So the role of surgery for this patient is unclear, but if you choose no surgery, they need frequent EGD to look for disease recurrence and scans, of course. But if there is a residual disease, of course, you take them back to surgery. So again, we're going back to the T2 that was taken to surgery without pre-op. This is a surgeon, just take the patient to surgery, then talk to you. They don't have any pre-operative or chemo or chemoradiation. Anyway, surgery being done, and now you see the patient. So what do? For the R0 T2 only, no lymph node, you can just watch them or offer them chemotherapy, especially if they have one of these high-risk features, poorly differentiated, high-grade, LVI or neural invasion, D2 lymph node not being done, or young patient less than 50. If there's any of these patients who has the muscularis involved, resected, and no lymph nodes, R0, those you offer them adjuvant treatment, which is the 5-FU Xeloda, the concurrent chemoradiation, 5-FU or Xeloda. This is similar to 5-FU, concurrent chemotherapy, and 5-FU or Xeloda. Again, for a patient, the T2 muscularis involved, have surgery, and you don't have the choice to give them any treatment before. They already have surgery and they come to you, and after surgery, it was a pathologic T3 or T4 or any N, or not positive. Those, if they have less than D2, less than 15 lymph nodes be removed, again, you give them the same chemotherapy, concurrent, chemotherapy, 5-FU or Xeloda, followed by concurrent chemoradiation, followed by 5-FU or Xeloda. But if they have a D2 lymph node dissection, you give them chemotherapy and no need for radiation. Again, the same patients with the T2, the same scenario, a patient with a T2 muscularis being invaded, they have surgery, and now they have an R1, residual disease. You can give them concurrent chemotherapy, which is a fluoropyrimidine, which is a 5-FU or Xeloda-based chemotherapy. Of course, R2, the same thing, or gross residual disease extends a lot left behind, then palliative therapy. For patients who are medically fit, surgically unresectable, of course, those the best is concurrent chemoradiation or systemic systemic therapy alone, and then scan. If they have a very good response, you may consider gastrectomy. Surgery. That's not all the patients, but you may have selected patient that is they may benefit from gastrectomy, even if they have been deemed surgically unresectable. Of course, if not non-surgical candidate, palliative treatment, systemic therapy, concurrent chemoradiation, or best supportive care. So in general rules for early stage, no negative, no ulceration, no LVI. The size of the tumor is small, less than 2 centimeters in diameter, and it is well differentiated. Those patients, endoscopic resection is acceptable. Remember, the GE junction and proximal gastric cardia cancer treated as esophageal cancer using preoperative concurrent chemoradiation. So we treat them similar to the distal esophageal adenocarcinoma or GE junction. What about the new adjuvant and adjuvant? So this is just few points about it. Upfront surgery, if it's D2, it's okay, especially if D2 has been done, more than 15 lymph nodes been resected, they're negative, and it's D2, observation is okay. But if it's an inadequate lymph node dissection, less than 15 lymph nodes been removed, those patients should offer them adjuvant treatment. For patients with a high grade or LVI or perineural invasion, adjuvant chemotherapy is recommended, even if it's a T2. This is just summary of all the other the slides for the T2 disease. For locally advanced and resectable, it's better to downstage them with pre-operative systemic therapy or pre-operative chemoradiation. That's just general rules. So now it is with the time of the precision medicine, we're looking for, trying to do better, because usually we use chemotherapy. So now there are two studies. One of them is a Keynote 585, patients with a gastric and GE junction, T3 or more, or lymph node positive. There have been now, there's a study now enrolling those patients into the platinum-based chemotherapy, cisplatin, with the fluoropyrimidine, 5-FU or Zolota, plus minus Pembro, Keytruda for 3 cycles, followed by surgery, followed by the same regimen for 3 cycles, plus minus Pembro, and followed by Pembro maintenance. Another study, which is the Matterhorn study, same thing. They enroll patients with stage 2, stage 4A. They gave them new adjuvant or preoperative FLOT for 4 cycles with durvalumab, which is Imfinzi, for 2 cycles, followed by surgery, partial subtotal gastrectomy, followed by FLOT for 4 cycles, durvalumab or Imfinzi for 2 cycles, followed by durvalumab for maintenance for 10. So these 2 studies may change the standard of care for stomach cancer. So far, we don't use immunotherapy for the non-metastatic disease, but this is here trying to incorporate the immunotherapy for the non-metastatic disease. So we are waiting. So now we move to the locally advanced or metastatic gastric cancer. So same case back to us again. So now, and the person who said to check the HER2, that you're correct. I think that is one of the questions. That is what we do. You're right. We check the HER2 for all advanced disease. We check HER2 by IC. So now the result came back. The HER2 positive 3+ by immunohistochemistry. MSI came back stable. MMR proficient or intact, so there is no deficient MMR, it is proficient or intact. PD-L1 score of 3%, remember this number, 3%, because that is, we use this for the guidelines. We have the cutoff of 1 or more, cutoff of 5. We'll see later about the use of the PD-L1 CPS or the combined positive score. And she is back now to clinic for a scheduled follow-up visit to decide on what to do. So what would you recommend now? Choose all correct answers. You can choose. Would you treat the patient with trastuzumab plus chemotherapy, Capox, capecitabine, or Zolota and oxaliplatin? Would you treat the patient with nivolumab and Folfox? Or would you treat with immunotherapy only non-chemotherapy regimen with nivolumab and ipilimumab, knowing that the CPS score is 3%, or would you treat with a dual immunotherapy, non-chemotherapy drugs, trastuzumab, pembrolizumab, or Keytruda, plus Folfox, or would you consider CRS cytoreductive resection, cytoreductive surgery with HEPEC? I think this is an I, HIPPEC, the mistyping. HEPEC, which is heated intraperitoneal chemotherapy, if she has good response to systemic therapy. You would do. So now let's just go over overview for the locally advanced a local advanced metastatic disease. The options are palliative chemotherapy, which is systemic therapy. We use chemotherapy, checkpoint inhibitors, immune therapy, targeted therapy based on NGS, or we do cytoreductive surgery with HEPEC. I think he is spelled right. Heated intraperitoneal chemotherapy, but that's only for patients with peritoneal disease, like our patient. Or chemoradiation or best supportive care. Systemic therapy, general rules for the systemic therapy. So the systemic therapy based on performance status, of course, patient comorbidities and toxicity of the chemotherapy. You choose chemotherapy based on the toxicity profile and the patient comorbidities. For example, the patient with diabetes, you don't want to use oxaliplatin, which causes peripheral neuropathy and so forth. For patients with HER2 positive, we use trastuzumab first line plus chemotherapy plus minus pembro if PD-L1 positive 1% or more. Remember, HER2 positivity is up to 20% of advanced gastric cancer and GE junction. So it is not a small number. So 1/5 of patients with gastric or GE junction, they may harbor the HER2 status. Remember the platinum, it is usually we say platinum-based chemotherapy, and everyone agreed that oxali preferred over cisplatin when you use platinum-based. So use oxali instead of cisplatin. This is a phase 3 study. It's a Keynote study, Keynote 811 trial. They study the dual use of PD-L1 inhibitor and HER2 blockade in HER2 positive gastric cancer. So those are patients with unresectable metastatic HER2 positive gastric cancer, adenocarcinoma. They are more than almost 700 patients. They gave them trastuzumab and chemotherapy plus pembro or Keytruda. And they found out the median PFS is 10 months versus 8.1 months, and the overall survival 20 months versus 16.8 months with the hazard ratio of 0.84. And they come up with this statement comparing this 4 drug regimen with placebo, which is and they found pembro significantly improved PFS when combined with the first-line trastuzumab chemotherapy for metastatic HER2 positive gastroesophageal cancer, specifically for patients with PD-L1 combined positive score of 1 or more. And the overall survival follow-up is ongoing and will be reported at the final analysis. So what about the nivolumab, another PD-L1 inhibitor, a PD-1 inhibitor, nivolumab or Opdivo. This is a follow-up for a randomized trial of more than 1,500 patients. They gave them nivolumab with or without, they give them the chemotherapy with or without nivolumab, and they use 5-FU oxaliplatin-based chemotherapy with or without nivolumab or Opdivo. And the follow-up for this study showed that adding nivolumab improved the 3-year overall survival rate, 17 versus 10%, but specifically for patients with the CPS combined positive score of 5 or more, the overall survival is 21 versus 10%, significant. So now with this follow-up study, now nivolumab with plus chemotherapy recommended as a first line for gastric and GE junction adenocarcinoma with the CPS score CPS of 5 or more. That's why I said in this patient the score was 3%. So in this, for our patient, pembro is recommended but not nivolumab because of the score. Because pembro is recommended for a score of 1 or more. Nivolumab, based on this study, it is for five or more CPS. So first line should be based on HER2 status. All gastric cancer before we give them chemotherapy. So we go to our patient, and instead of go ahead with chemotherapy or surgery or anything, first thing to do, check the HER2 status before you commit the patient to any treatment. That is a standard of care. So you should check for the HER2 as one of you said, check the HER2 status. That is first, that's correct. And for those patients, if it is positive, the recommended regimen is Folfox or Zelox or Kbox, which is oxaliplatin 5-FU or Zelota, plus trastuzumab. And if the PD-L1 score is 1 or more, then you add Pembro or Keytruda. If HER2 come back negative, then you have multiple options. You can just give chemotherapy by itself, which could be Folfox, Zelox, or cisplatin, fluoropyrimidine is fine. Then you look into the PD-L1. If the PD-L1 is 5 or more, you add nivolumab. If it is 1 or more, you add Pembro. As simple as that. So basically, it's HER2 negative. So first you check HER2. If it's positive, trastuzumab. Then you check the PD-L1 status. If it is more than 1, you can add it to the trastuzumab and chemotherapy. If the HER2 is negative, then you add nivo. If the PD-L1  5 or more, if it is 1 or more, your choice is Pembro. For first line, for patient, these are regardless of the PD-L1 status. If they are, then your choices are many. So for the non-chemotherapy regimen, you could use checkpoint inhibitor by itself, like Pembro, Keytruda. You could use Nivo, Ipilimumab. You can use the dostarlimab. Or you could use chemotherapy along with the immunotherapy. So you have options, but you do not need the PD-L1 if they are MSI high or MMR deficient metastatic disease. This is all first line. Of course, there are other first line, which are traditional chemotherapy. You can use 5-FU on irinotecan, like FOLFIRI, Taxol, platinum, dossier with the cis. You can 5-FU Zelota. Second line, these are many second lines. If they fail the first line, these are your second line. Remember, on the second, third, or fourth line, anything after first line, I highlight here for patients who are HER2 positive, failed second line, you have the option of a different HER2 drug, which is in HER2. For patients with the MSI MR deficient, you have the immune therapy only. This is just and now it is the time now, or now we look into treating the cancer not based on organ or system, based on tissue biomarkers. So regardless of the primary, so what we call tissue agnostic. So any tumor, regardless of what it is, if the TM where it's coming from, if it is metastatic and TMB high more than 10, you could use Pembro. So NTRK positive, you have options. All these are BRAF, you have an option. So these are based on biomarkers. That's what we said. We look into NGS to look for tumor biomarkers, which you call tissue agnostic therapy. This is just a cartoon, brief summary. So if you have a stomach cancer, then you have done surgery, and then the outcome, you have an R0, then if it is a TIS or T1, then observe. If it is a T2, observe, or better to give concurrent chemo radiation for high-risk patients, or chemo is given pre-operatively. If it's a T3, T4, or any node positive, then recommended radiation chemotherapy or chemo if given pre-operatively. And if it is an R1, concurrent chemotherapy. And if it's an R2, concurrent chemotherapy or best supportive care. Of course, if it is metastatic, then palliative therapy, which could be systemic therapy or best supportive care. Then this is the end for the stomach cancer. And this is a take-home message. So for proper management of early stage gastric cancer, You need a good biopsy for accurate staging. Consider EUS or laparoscopy. It helps you to decide what to do. For any patient with a clinical T2 tumor that invade muscularis or more, it should be actually muscularis. Submucosal for, no, this is a type error. Should be tumor invading the muscularis, not submucosal. Submucosal, that's a clinical T1B, sorry. So a T2 invade the muscularis. Those patients always use pre-operative, or perioperative chemotherapy, preferred chemotherapy for surgery, and chemotherapy after, or pre-operative chemoradiation. For patients with metastatic disease, always check MMR and MSI status, always check the HER2, always check the PD-L1, and maybe NGS if available. All patients with HER2 positive and PD-L1 positive, one or more, should treat them with chemotherapy, trastuzumab, and Pembro or Keytruda. This is the end of the stomach cancer. If anyone has a question before we go to the pancreas. Are you guys, are you okay so far? Any comment? Okay, well, we go to pancreatic cancer. So presentation of pancreatic cancer symptoms: anorexia, painless jaundice, weight loss, new onset diabetes, mild back pain, splanchnic plexus involvement due to that, nausea, vomiting, duodenal or gastric outlet obstruction causing nausea, vomiting, and staturia. And signs of pancreatic cancer: palpable gallbladder or Covizier sign, migratory superficial phlebitis, Trousseau syndrome, ascites, left supraclavicular lymph node enlargement, Virchow nodes, or periumbilical mass, Sister Mary Joseph node or nodule, a Schmidt's triad, which is pancreatic panniculitis, xenophilia, and polyarthralgia. This is a clinical sign of pancreatic cancer. Diagnosis: you need a pancreatic protocol CT or MRI abdomen. Spiral, that's what we call a spiral CT, which describe for us, give us better idea about the vascular encasement. Of course, you need a biopsy. And the biopsy could be CT guided biopsy, or it could be through EUS. By the way, EUS is very helpful for pancreatic cancer. The accuracy for pancreatic cancer, 85 to 90%. Lymph node metastasis, 50 to 70%. And it's good to evaluate portal vein and SMV involvement, less helpful for SMA involvement. This is about the EUS. MRC or ERCP is one of the tools for pancreatic cancer. PET scan, of course. Diagnostic laparoscopy sometimes needed, and to check the CA19-9. And of course, remember, CA19-9 is not a diagnostic test. It is a prognostic tumor marker. So we only do it if we diagnose pancreatic cancer. So it's not for diagnosis. So a case: a 63-year-old male patient with history of type 2 diabetes presented with deep jaundice. CT scan of the abdomen showed a 2-centimeter dense tissue at the head of the pancreas. He underwent ERCP with successful stent placement, which is typically that we do, and brushing biopsy, which showed poorly differentiated adenocarcinoma, CA19-9 elevated at 650. So what would you do next? So would you take him to surgery? Because he has only tumor in the head of the pancreas and nothing else seen. So you take them to surgery for Whipple procedure and surveillance, or would you take him for surgery and follow that with adjuvant radiation therapy, or take him to surgery for Whipple procedure followed by adjuvant modified FOLFIRINOX, or would you order an EUS endoscopic ultrasound and spiral CT abdomen or MRI? Which one you do first? Anyone? Someone said number 4. Okay. Ala Mukhtar. Ala Mukhtar. Ala Mukhtar. Okay. Okay. So let's just. Okay. Okay. So let's just move forward and see where we go from here. Okay. Pathology. 95% adenocarcinoma, which is an exocrine gland ductal system. It could be an acinar, but adeno is the most common. Mucinous cystic neoplasm. And 2/3 of patients with pancreatic cancer are in the head of the pancreas. 2/3 of pancreatic cancer head of the pancreas. Genetic testing. So all pancreatic cancer, any patient with pancreatic cancer, diagnosed pancreatic cancer, should have germline genetic testing. And then we check for the BRCA, 1, 2, ATM. So we check all cancer of the pancreas should be offered germline testing. For locally advanced or metastatic pancreatic cancer, we should do NGS, next generation sequencing testing for somatic mutation. Why? Because we may find a target and a medicine, a drug that correspond to those targets. So NGS is also should be considered, and check MSI and MMR, tumor mutational burden, TMB, sorry. So pre-treatment evaluation for pancreatic cancer. Start with the staging and assess for resectability. That's a key. So all pancreatic cancer, before we jump into any treatment, like in our case, instead of take them to surgery, and you're right, Ala said to do the EUS, CT, or MRI. So we only do CT scan. It should be a CT scan with contrast, 3D CT, spiral CT, not a regular CT. So it's the pancreas protocol. So don't order just a CT scan. It should be a CT scan, 3D or spiral CT scan, and mention to the radiologist, this is a pancreatic cancer protocol. So they can describe for you the vasculature and the relation of the blood vessels to the tumor, the tissue plane between the tumor and the blood vessels. So that's needed for staging and resectability. So, and you need an EUS, and we said about how accurate is the EUS for the pancreatic cancer. So EUS, CT scan, or MRI are needed before you jump into any treatment. You may also consider doing laparoscopy, especially for tumor in the body or the tail of the pancreas, which is not that common. But if it is, and then laparoscopy is needed because EUS doesn't reach there. But laparoscopy can help you. And you need laparoscopy prior to surgery or neoadjuvant therapy, and for patients with high risk features. Now, after you do that, you will come with one of the following. This is your assessment. Either the tumor is resectable, or the tumor is borderline potentially resectable, or a patient not metastatic but unresectable, or metastatic. So that's why for any pancreatic cancer, you should do these things before making any decision, and because the best treatment is the best to do for any cancer in general, but for pancreatic cancer, before we start any treatment, do these things and prepare from day zero with a good roadmap And of course, you take all this information to your tumor board, multidisciplinary meeting, where you have your pathologists, your radiologists, radiation oncologists, and medical oncologists, the whole team, to decide the treatment before we initiate any therapy. So these are the treatment modalities. If the patient has obstructive jaundice, we should do an ERCP with stenting. And remember, self-expandable metallic stent, SEMS, preferable to plastic stent. And if the stent is not feasible to relieve the obstruction, then you may need a percutaneous biliary drain, PBD. For patients with gastric outlet obstruction, consider gastrojejunostomy or venting percutaneous endoscopic gastrostomy, PET tube. Pancreatic cancer is known for pain that radiates to the back. It could be severe pain. So pancreatic cancer, we need to provide them with opioid for pain control, or even opioids sometimes may not work, and you may need to do celiac plexus neurolysis or celiac plexus radiation, which is radiosurgery, or even radiation therapy. Whipple procedure is, of course, the standard procedure. Chemotherapy, this is just the treatment modalities, this in general. Chemotherapy, concurrent chemoradiation, targeted therapy based on NGS, or immune therapy, checkpoint inhibitors. These are the modalities that we may use for your patient with pancreatic cancer. So now we go back to our case. So you have done the spiral CT scan, which show the tumor is encasing the SMA, but no evidence of metastasis. So this is a locally advanced, but no metastasis. Of note, because we said all patients with pancreatic cancer, you need germline testing, so you have done that, and it showed BRCA2 gene mutation. So what would be your recommendation? So locally advanced, BRCA positive, no metastasis. So would you recommend neoadjuvant gemcitabine Abraxane followed by Whipple procedure? Or Whipple procedure upfront and concurrent chemoradiation? You do Whipple procedure, take them to surgery, and then because of the BRCA positive, prescribe for the patient PARP inhibitor olaparib for 2 years? Or would you give the patient neoadjuvant chemotherapy, modified FOLFIRINOX, then do the surgery, then back again, give chemotherapy, FOLFIRINOX, or concurrent chemoradiation? Anyone? Rajab Hamid, number 4. Let's go over these. So now, after that assessment, and you have done your US, CT, MRI, all of those stuff, you have done all that, and now let's just go over our group, the four situations. One of the situations is you define the patient has a resectable disease. This is just a definition for resectable. I don't want to go over those. You can just read them later on, but this is the resectable. It could be arterial, based on arterial finding or venous finding. This is the, so there is no arterial or venous involvement. So for resectable. So this is the phase 3 study, pre-op-PANC trial. What they have done, they look into the neoadjuvant or preoperative therapy for potentially resectable disease and borderline resectable pancreatic cancer. They said their conclusion is the preoperative or neoadjuvant therapy improved survival compared with upfront surgery followed by adjuvant therapy. Their data showed a difference in median OS. It is small but significant, 15.7 versus 14.3. However, the 5-year overall survival substantially higher, 20.5 versus 6.5%. And there is a meta-analysis of 7 randomized trials, all of them, including this clinical trial, all of them favor neoadjuvant therapy, which said it improved overall survival. So it became a standard of care. So resectable disease or tumor, you could do surgery. You could do surgery upfront, but you have to fulfill this criteria. No high-risk features, none of this. So the patient should not have an equivocal or intermediate imaging findings if these things are not clear. You know, sometimes the report you or the radiologist not commit to anything. So that means it's equivocal or indeterminate imaging findings. Then don't buy that. Go and give chemotherapy, not take to surgery. Or if the CA19-9 is markedly elevated in the 1,000, the primary tumor is large, even if it's not invading vessels. Large regional lymph nodes, of course. Excessive weight loss is telling you that the disease is more than what you see. Extreme pain, same thing. Extreme pain is just telling you that is the CT scan finding does not correspond to the real life. So those ones you should not take them to surgery. So you give them adjuvant chemotherapy. If you have done surgery, then adjuvant chemotherapy, or for resectable, then neoadjuvant. And actually nowadays, everyone prefer neoadjuvant because sometimes scan doesn't tell you the whole story. So pancreatic cancer is a bad disease. So if there is a way to give chemotherapy, give it before surgery, neoadjuvant, preoperative. Chemotherapy or chemoradiation, you give it for 6 months, either pre or perioperative. If you use pre, you complete 6 months. If it's not complete 6 months, give before, and the rest of the 6 months you give it after, like 3 of FOLFIRINOX, followed by surgery, and you will see in one of the clinical trials that we in the coming slides. And then restaging after the neoadjuvant. But remember, if there is a progression after the neoadjuvant, that should not preclude surgery. Just what you could do, you just use a different chemotherapy. So if you have used gemcitabine in the neoadjuvant, and there is a progression, but not metastatic, talking about progression, not metastatic, increase in size, something like that. Then don't say this is a failure, I'm going to surgery. Just choose your preoperative or neoadjuvant chemotherapy, something else like FOLFIRINOX. So basically, the message is try to give chemotherapy, and we'll tell you the rationale for the why we do chemotherapy. I think it's coming. So for resectable, either you do open procedure. So all patients, or if you see the patient after surgery, so the surgery is already done, you have not been consulted, and the surgery is being done for whatever reason, then all patients, remember this, all patients with pancreatic cancer, even a T1, who have not received neoadjuvant chemotherapy, this is very important. All pancreatic cancer, even a T1, not receiving neoadjuvant chemotherapy, should receive adjuvant chemotherapy for 6 months. This is standard of care. This is the guideline now. Except the only time you do not offer chemotherapy to pancreatic cancer who had surgery are patients with well-differentiated acinar T1 cancer. So this is the only group that you do not offer chemotherapy to resected early-stage pancreatic cancer. So this is the only group. Otherwise, just remember this: all pancreatic cancer, T1, even T1, who have not received neoadjuvant chemotherapy, should offer them adjuvant chemotherapy. On the other hand, or other way, you can say all patients with pancreatic cancer should receive neoadjuvant chemotherapy. Basically, that's what it's telling us. But if the surgery was done, offer them chemotherapy for 6 months, except this subset of patients, acinar, well-differentiated T1 lesion. So if you choose to do chemotherapy, or you're going to do chemotherapy, the patient is fit, FOLFIRINOX is the best. It gives you the best outcome, especially if the patient had a BRCA gene mutation. like our patient. If the patient is not fit, then gemcitabine or gemcitabine, with or without capecitabine or Xeloda is another alternative for a patient that's not fit, or Xeloda by itself, capecitabine. You could use that chemotherapy, concurrent chemotherapy, followed by with or without chemotherapy. Remember, if gemcitabine-based adjuvant chemotherapy is used, concurrent 5-FU and radiation should be given, especially if not positive or margin positive. So if you use adjuvant gemcitabine, follow that with concurrent radiation, which is the 5-FU during concomitant with radiation therapy in patients with a positive margin or positive lymph nodes. This is just a few points about the adjuvant therapy. So adjuvant therapy should be given within 12 weeks of surgery, 3 months within that time. If you choose chemotherapy, if you alternate between chemotherapy and chemoradiation, whenever you change the modality, you should scan. So if you use chemotherapy and then gemcitabine, and you want to now give concurrent 5-FU and radiation, you should scan in between. Have a baseline scan. The Canco 001 trial, just telling us that adjuvant gemcitabine or gemcitabine in resectable disease significantly improve DFS and OS, overall survival. The SPAC3 study telling us that's short message from these studies. No significant difference in overall survival between adjuvant 5-FU and gemcitabine. So if you use gem or 5-FU leucovorin, they're equal in the adjuvant setting. SPAC4 also saying that if you use gem, it's better to add Xeloda or capecitabine to it. So gem oxali is superior to gem alone. From RTOG 9704 study, they said if you use concurrent chemotherapy, if you use 5-FU or gem, are the same, no difference. So if someone chose to give concurrent chemoradiation using 5-FU or using gemcitabine during radiation, are equal. And here, based on the Lab 07 trial data, showed that is actually the addition of concurrent chemoradiation after gemcitabine, the benefit is unclear. However, the same study telling us that the concurrent chemoradiation may improve local control and delay the need for resumption of therapy. This is just a few points on the adjuvant therapy. So what about the borderline resectable disease? These are the definition of what we call borderline. I'm not going to go through them. Just you can come back to them later. This is based on this is more anatomy, and this is more useful for the surgeon. So now we move to the preoperative or the new adjuvant therapy. NCCN recommending new adjuvant therapy to the following. In case of high risk, potentially resectable, should give new adjuvant. If the imaging is concerned with the concerning findings, very elevated tumor marker CA19, 9,000 or so, large primary, large regional lymph nodes, excessive weight loss, extreme pain, as we said, these things telling you what you see is less than real life. New adjuvant regimen is not defined. So there is no really defined new adjuvant. So whatever you choose is fine, but everyone agree that is there's more and more evidence that is modified, or actually the standard FOLFIRINOX is preferred over gem-Abraxane, especially in patients with the BRCA gene mutation. And if you do surgery, follow that with adjuvant concurrent chemoradiation or chemotherapy. So here is the rationale so why we insist to give preoperative or new adjuvant therapy for pancreatic cancer, even for a stage 1. It provides an opportunity to eradicate occult micrometastatic disease. Pathologic downstaging can prove surgical, can improve, this is to be improved, type here, improve. So pathologic downstaging may improve surgical outcome. adjuvant therapy may be delayed due to complexity of pancreatectomy. So if you rely on adjuvant therapy, it's better to give it before, because after surgery, because Weber procedure is a big surgery. So treatment could be delayed due to the complexity of the pancreatectomy. So that's why it's better to give it before rather than after. This is a paper recently published in JAMA, just recently, this year actually. This is published by Michael Cicchini and his group. It was a non-randomized controlled trial about basically try to answer this question: does perioperative, before and after, modified FOLFIRINOX improve survival in patients with resectable pancreatic ductal adenocarcinoma? So that's a question for the study, very simple. So what they did, they gave modified FOLFIRINOX for 6 cycles, then surgery, then modified FOLFIRINOX for 6 cycles. And they said their 12-month PFS is 67%, which met the primary endpoint of the study, which is their endpoint was more than 50% PFS. They have 67%, so they met their endpoint. And the median overall survival was 37.2 months. And patients with detectable circulating tumor DNA level 4 weeks post-resection had significant worse rate of PFS and overall survival. So very interesting study. So new adjuvant prefer to be FOLFIRINOX or modified FOLFIRINOX, with or without chemoradiation after surgery. Gemcitabine and Abraxane combination doublet, with or without chemotherapy, is acceptable, especially if your patient is not fit, because FOLFIRINOX, you need a fit patient. You need a patient in a good shape to handle FOLFIRINOX, because here you're giving everything. You're giving irinotecan, 5-FU, oxali, you're giving everything. So for patients who are known to have BRCA1 or 2 gene mutation or PALB2 mutation, those patients, they benefit more from FOLFIRINOX. Those are the patients for FOLFIRINOX rather than the Gem-Abraxane. Another option is Gem-Cisplatin is okay. For borderline resectable, if they have local advance and they are in good shape, good or intermediate performance status, clinical trial, of course, all the time is good. But induction chemotherapy is the way to go, followed by concurrent chemoradiation. If they're not candidate for induction chemotherapy, then offer them concurrent chemoradiation or SBRT, then followed by resection, with or without adjuvant therapy. This is for the borderline. For the locally advanced unresectable, you know from the beginning, this is the definition for the local advanced unresectable. As I said, you can go for that later. This is more for the surgeon. This is the definition when we describe patients have local advanced unresectable. You can read those. This is arterial and the venous description of unresectability. Local advanced or unresectable, defined as extensive peripancreatic lymph nodes enlargement, lymph nodes beyond peripancreatic tissues, direct involvement of SMA, IVC, aorta, celiac axis or hepatic artery, SMV, portal vein, occlusion or thrombosis. For those patients, everyone agrees that is we give them adjuvant chemotherapy and hope for the best to see if they're resectable or not. So for those patients, if they happen to have surgery and there is no new adjuvant treatment given, then treat them in a clinical trial, chemo followed by chemo radiation followed by chemo. But if they happen that you give them chemotherapy and they are lucky, they respond, they have surgery, consider either chemo or chemo RT if positive margins. And here are the regimen for the locally advanced unresectable disease. You can see the list. You can see FOLFIRINOX now at the top of the list, Gem, Abraxane, and then there's a new regimen which is Naliri Fox. We'll see that later. And on the left side is agnostic regimens based on the tumor biomarkers. Now, again, back to our case. Be ready for the question. So you have treated the patient successfully with new adjuvant, modified FOLFIRINOX for 6 months, and you sent to surgery and had a Weber procedure and received adjuvant concurrent chemoradiation. So you have done, that's option number 4, as you guys said. That's fine, that's the right answer. You have done that, that's correct. Now, you have been monitoring the patient closely with tumor marker CA99 and serial scans and has been doing fine for 9 months. Unfortunately, the CT scan now showed an isolated 3.5 centimeter liver lesion consistent with metastasis. So isolated liver metastasis, 3.5 centimeter lesion. What would you do? So choose one answer. If you can answer, it'd be great. Just try and see what we do. So option number 1, metastatectomy and or partial hepatectomy to remove the tumor, followed by gemcitabine and capecitabine or Xeloda. That's option number 1. Option number 2, give the patient cisplatin and gemcitabine combination, platinum base, to a maximum response, followed that by PARP inhibitor or olaparib. Remember, the patient had a BRCA gene mutation. Or treat with immunotherapy, pembro, or radiofrequency ablation. Well, see if anyone had the, let's just see. Option number 4. Oh, there's more than one. Option number 2. And option number 4. I just see which one is the best. Sometimes in oncology, there is not right or wrong answer, but the best, try to see what is the best option. So let's just see from literature which one should be the best. Okay, so for metastatic disease, remember, all patients with metastatic disease, we said that before, we check them for genetic testing. So if they have no BRC or BALB2 mutation, the chemotherapy is FOLFIRINOX for FOLFOX. These are the regimen for metastatic disease. If they have BRCA or PALB2 mutation, platinum base like FOLFIRINOX or FOLFOX, followed by maintenance PARP inhibitor. So if they have BRCA gene mutation and they're metastatic, this is option number 2, correct? Which is cisplatin gem, and after a maximum benefit, stable disease, not progression, then maintenance PARP inhibitor. That was the correct answer, the option number 2. Because usually for metastatic pancreatic cancer, even if it is an isolated, there is no data showing that metastatectomy for pancreatic cancer is helpful. I'm not aware of that. We could do that for colorectal cancer. There is data for colorectal cancer, which is liver resection, hepatectomy, or ablation. But for pancreatic cancer, I'm not aware of any pancreatic cancer with metastatic disease. It is systemic treatment. So for the people who said ablation or hepatectomy is, I think I would say fine, but there is nothing to support that. That is mainly for other cancer. For colorectal cancer, yes, we do. For isolated liver disease, resection, and ablation is fine. But for pancreas, our best option is platinum-based chemotherapy, any platinum-based FOLFIRINOX, FOLFOX, and cisplatin gem. In this case, I chose the cisplatin gem because the patient already been exposed to FOLFIRINOX and had a relapse, even the relapse 9 months later. But changing chemotherapy to cisplatin is a platinum-based, and then after the response and stable disease, the recommendation for the PARP inhibitor maintenance for BRCA2 said the patient has to receive treatment for 16 weeks, which is like 4 months. which is an average. Then stable disease, follow that with PARP inhibitor maintenance for BRCA2 positive. And we'll talk in a coming slide about the maintenance treatment options. So patient with deficient MMR, MSI high, immune therapy, checkpoint inhibitor is one of the options. So phase 3 Napoli 3 clinical trial. It is a randomized open label phase 3 study investigating the efficacy and safety of NALIRIFOX, which is the liposomal irinotecan, sulfonylurea, and oxali. Basically trying to find another regimen which is compete with the two commonly used regimen, which is the FOLFIRINOX and gem-Abraxane. So this is another option. So they compared this head-to-head with the gem-Abraxane at the first line in patients with metastatic pancreatic cancer, and 80% of the patients have liver metastasis. So in this study, the objective response for NALIRIFOX is 41.8% versus 36.2%. And NALIRIFOX improved overall survival, 11.1 versus 9.2%. So at least we have another option, combination chemotherapy for pancreatic cancer, because this disease, we used to have very little, I mean, 1 or 2 regimen, but now I have more regimen. This is proven to be effective, and it's another option other than FOLFIRINOX, which is really a rough regimen. The interesting finding, the grade 3 and 4 peripheral neuropathy is less frequent in NALIRIFOX, which is, I find it interesting because this is hydroxychloroquine, and the gem-Abraxane doesn't have the neuropathies, usually we see that more with oxali, but they said in this study it is less frequent. These are the chemotherapy options or systemic therapy options for metastatic disease, very similar to the advanced disease. On the left side is the conventional chemotherapy. On the right side is the agnostic tissue agnostic options based on NGS, next generation sequencing. But we said nowadays we could use drug not based on the organ or system. It is more based on tissue, regardless of where the tissue comes from. So if the patient has any of these, like the BRAF, mutation, we use the dabrafenib, and then for patients with the KRAS and patients with HER2, we use Enhertu, and so forth. So that is why we recommend to do NGS for metastatic disease. So here are the options of the maintenance therapy for pancreatic cancer. So after platinum-based BRCA positive, we use PARP inhibitor, olaparib, or rocaparib, one of them. Olaparib or use more frequent, but either one is fine. After first line FOLFIRINOX, the patient, they are not BRCA positive, of course. Then after they achieve the maximum benefit, because you cannot give FOLFIRINOX forever or for a long period of time. After you have progression, stable disease, then we switch them to either capecitabine, Xeloda, or 5-fluorouracil, or even FOLFIRI or FOLFOX. So basically, you just take out one of the drugs, FOLFIRINOX, make it FOLFIRI by taking out irinotecan and oxali, or taking out irinotecan and make it FOLFOX. But this is for maintenance. After first line gem-Abraxane, you can give either gem-Abraxane or the whole thing. This is based on patient tolerance. This is for maintenance therapy for metastatic disease. This is the last slide. This is a take-home message. Staging and evaluation for resectability should be done for pancreatic cancer, non-metastatic, and that is done by spiral CT or 3D CT, or what some people call it pancreatic cancer protocol CT, EUS, or laparoscopy. So before we jump on any treatment, if we already know this metastatic, we don't need that. But if it is newly diagnosed, and we try to put your recommendation for the treatment before we jump on any treatment, this is what needs to be done to decide, to define resectable, borderline resectable, and resectable or metastatic. So resected, this is again, I'm just going to stress on this, resected all stages, not pancreatic cancer, not received new adjuvant or preoperative chemotherapy, all of them, regardless of the stage. If they are not metastatic, they should receive adjuvant chemotherapy for 6 months. The only exception is well-differentiated acinar T1 pancreatic cancer. They don't need the adjuvant, but otherwise everyone does. For all metastatic disease, genetic testing is needed. We check for the BRCA gene mutation, and if it is after platinum-based chemotherapy, we give them maintenance PARP inhibitor, like our patient. And patient with metastatic disease, we should check for MMR and MSI. If MMR deficient, MSI is high, we treat with immune therapy checkpoint inhibitor. We use pembro. And this is the last slide. Thank you much. Any comment, any question?
I have a question. What about tumor burden in pancreatic cancer? هل متوقع ألقاها هاي I am asking about tumor burden in pancreatic cancer.
ده tumor mutation burden.
أيوة الدوميننت إنه أنا ألقاه شنو ألقاه هاي ألقاه له والsignificance حقها.
Oh, okay. So high or low, I'm not sure if I know the answer for that. I mean, you're talking about the incidence of that. I don't know really, but the significance of that, if the TMB is more than 10, then you could use immune checkpoint inhibitors. That's significance. That's the significance of that. So if so basically for the checkpoint inhibitors, you either need, of course, the MMR, MSI, or the TMB. So the TMB more than 10 is considered high, 10 or more. So if it's 10 or more, you may consider using the checkpoint inhibitor, pembro or nivo, or nivo with ipilimumab. Yeah. But how the incidence of it in pancreatic cancer, I need to look. I'm not sure. If anyone knows.
مزيد من الأسئلة. أنا أفتكر إنه المحاضرة كانت محاضرتين يعني تستحق إنه يكون فيها أسئلة أكثر. لحد ما يسأل أحد دكتور شامي أنا بس I want to see your experience regarding giving anti-HER2 في metastatic gastric cancer. Yesterday I have a patient with high meridin metastatic gastric cancer, lung, bone, lymph node, peritoneal, peritoneum, برضه كان involved, even the pancreas. I started FOLFOX, and then later PDL1 came as less than 1, and HER2 come +3.
Oh, okay.
For sure, I started. I at that time in our pharmacy there is two type of HER2, subcut and IV. It was easy for me to give subcut, but until yesterday I didn't find any that support giving Herceptin subcut in metastatic gastric cancer. It is not like the breast. I don't know if you have any.
Honestly, I don't. I don't. All the gastric we use the IV, but I can tell you, I think it is even for the breast. I don't think it's been studied as I mean, like head to head, but it said that is in any situation, whenever IV trastuzumab is used, you could use the sub-Q.
Interchangeable,
yeah. I think I will look into that, but I don't think there's any comparison. But the bioavailability of the drug, as long as trastuzumab is indicated, you can use the sub-Q.
Yes,
but you're right. more data
Yes,
for
all
the
the
breast.
data have been studied in the breast. Like
The breast,
for
correct.
example, if you can compare Zoladex every 3 months, I can use it in the prostate, but still I have no data to use it in the breast.
That's right. Yeah. What do you mean? I mean, you're trying to say that. I mean, I don't think we have a scientific evidence of that, but the logic says that because it is all about the bioavailability of the drug, correct? So if it is, I guess if it is, if it does a job for the breast, it will be the same for the. But you're right. You remember the dilemma also for the HER2 testing, because usually it was for the breast when we use the IHC, and then when we tried to use it for the stomach, at one point it was kind of an issue. Like 3+, 2+. Do we for the breast we do the fish? Do you do the fish for the gastric? So all these are, I don't think, being addressed properly. But if the drug is available IV, I will use the IV. But if there is no choice, I think I would use a sub-Q.
That was happening. Yes, I give IV and cut it short.
Yeah. If I have not used personally, I have not used a sub-Q for the gastric. It's all the time IV. I never even thought about it, to be honest with you. Because here we have insurance issues. If you prescribe it for, I don't think they're going to be approved.
Yeah.
Because IV, you're right. But if
any question from the audience?
So you're saying that you've been using the sub-Q, or what you? Because you said the pharmacy only have the sub-Q, correct?
No, we have both.
I'll have both. Then I would use the IV, yeah. But I'm not aware of anything for sub-Q for the gastric, yeah.
اوكي. انتظر سؤال قبل. انا عندي كان تعليق اخر لكن حابب اسمع من الشباب. شباب دي اللي تاني ندخلهم باسماء وهميه عشان ياخذوا راحتهم.
احسن. Case. And really the question, I don't mean the question that is kind of asking question, but I found out usually whenever there is a case, it will be because when we have a real patient, usually stick to our brain better than theoretical. So making a case, I think it helps to remember the discussion rather than just being theory. I think that's what I saw.
لكن ماذا نفعل؟
Yeah. So I don't mean making case like questioning people, but just to make it more interactive, if that's okay.
طيب السؤال الثاني يا دكتور شامي بالنسبة بري اوب بالاسروسفير جانكشن. Still you have a data strong to give float that compare with medical trial and cross.
Oh yeah.
This is the dilemma between radiation oncologist and medical oncologist. What do you prefer? I'm clinical.
You mean for the stomach, if you talk about float versus
سؤال؟
لا ما سمعت كويس.
قصدي انت ما سمعت سؤالي صح؟
لا ما سمعت كويس.
قصدي still we have a data to give float as new adjuvant for gastroesophageal junction.
Yes, yeah.
Adenocarcinoma, and also we have data based on cross trial.
Yes.
So giving float or giving cross still, what do you prefer as a medical oncologist?
Float.
Float.
Yeah, I said.
Now you have a data. You have an evidence.
Yeah, actually, this is more of a practice. You're right. I don't think there is a way to study this, but it's just been. I think there was a phase 2, I guess. You remember the same thing for the lung when we use the weekly carbotaxol. We never had a data to support using carbotaxol concurrent with radiation, but it has been used everywhere, correct? I think just because of it has been used. I think there was a phase 2 study for the float, but I don't think there is a strong evidence to support that.
No.
It's just more tolerable, and now it is being used.
I use both now, but now I think a few months now based on ESOPEC trial. You know, this is presented in last ASCO. Compare float and cross, and I think it comes at the conclusion now supporting the medical oncologist rather than radiation oncologist.
Oh, I think, you know what? I need to look into that. I think we use float all the time. I don't think we use any, just all the time is float.
Supporting now. It's support float now.
So okay, I actually need to look into that study too, actually.
I use both, but I'm not happy with giving new adjuvant chemoradiation as new adjuvant in gastroesophageal junction, a lot of toxicities and some side effects.
You're right.
But if you are looking for pathologic clinical response, I may think of. But at the end, a conclusion of ESOPOC comes out to give float, improve survival, if resectable again. It is not.
Yes, I agree. And on another, I think another reason people prefer float rather than the chemo radiation, surgeon prefer not to have radiation.
Yes.
If they have to go for the the oesophageectomy or any surgery, they prefer, for us, if we can give chemotherapy without radiation, just make their life easy.
اوكي طيب لو في سؤال يا شباب ما في سؤال طيب اوكي جمعة سعيدة دكتور شامي
الله يبارك فيكم ويديكم الصحة والعافية.
في